This is the second EXIMIOUS Symposium, and today's theme is on immune-mediated diseases, an interplay between environment and genetics. And so I try to be the chair of this session. I'm Peter Hoed from KU Leuven. And first, I will show you in 2 slides, or explain in 2 slides, what is EXIMIOUS. And then we will come to the session itself in 3-4 minutes. So the EXIMIOUS project is an EU Horizon 2020 project, which runs from 2020 until 24. We have a budget of 10.8 million, 15 partners from 7 different countries in Europe. And so our project is a typical, EXIMIOUS is a typical human exposome project in which we try to make a link between human exposure, external, internally, linking to human genome. And our specific focus is on the responses of our immune system. So we are focusing on immune-mediated diseases. So that's very brief. If you want to know more, you can go have a watch on our website. But just because I'm here speaking from KU Leuven, because we are the leading partner, but as you can see, we have 15 partners, so it's a big project with different cohorts, looking at occupational cohorts, diseased cohorts, and general population cohorts all over Europe. So it's a big challenge. But even the challenge is a bit bigger in the whole framework, because EXIMIOUS is a part of or one of the 9 European exposome projects together running in Horizon 2020. You have the 9 names here. So if you want to know more about these different exposome projects, you can find their websites on the EHN, so the European Human Exposome Network. But coming to the point of today, so this symposium on exposome-immunome interactions and immune-mediated diseases, we try to build a bit from the clinic to more specific biological responses. So general view first, and that has been done by Professor Langhe from UZ Leuven on autoimmune disorders. What does this mean, and what is the clinical relevance? And then we have a second session by Signe Hjuler Boudigaard on occupational exposures to respiratory crystalline silica and the risk on autoimmune rheumatic diseases. Then talk from Michael Pollard from Scripps Research on environmental exposures, genetics, and autoimmunity. And then final talk will be by Tue Bjerg Bennike from Denmark and on autoimmune diseases and the breach of immune tolerance. So just a few practical things. You can find on your screen a chat box when you look into the application of Zoom, or you can have a Q&A label button. And so if there is any technical issue in the connection and you think it's our side, you can inform us by the chat. If you have a question, please post the question in the Q&A box. So our first speaker is Professor Langhe from the UZ Leuven. So the clinic next to our university. In fact, she's an assistant professor, and she is into clinical work in systemic diseases, and she's also leading some research on skeletal biology and environmental research in general. So her domain of interest is mainly improving prevention, diagnostics, and management of patients of systemic diseases, with really the focus on environmental factors in sclerosis and other inflammatory immune-related diseases. So I give the screen and the parole to Professor Ellen de Lange. So I stop sharing my slides now.
Thank you very much, Peter, for the kind introduction. I will now try to share my screen, but I cannot as long as.
But I, yeah, stop.
Yeah,
yeah.
work.
Sorry.
Okay. Then use the pointer. So I assume everybody can see my slides now. Maybe somebody can confirm that it is working.
I can.
Okay, thank you. My name is Ellen de Lange. Indeed, I'm a rheumatologist working at the University Hospitals of Leuven, so the University Hospital of the KU Leuven. And as a rheumatologist, I am primarily involved in the care for patients suffering from systemic autoimmune diseases. I am mainly a clinician, so active as a clinician, and I was asked to give you an introduction, and the title that was provided to me was "What autoimmune disorders? What does this mean?" and clinical relevance, which is in a sense a very broad title, and I want to be very clear. I am aware that the audience that I'm talking to is very diverse, and so I think some of the topics I'm discussing, I will stay very much on the surface. So for the clinicians among us, it will be not a lot of new news, but I've been told that there are also non-clinicians here. So I see this as an opportunity to guide you also to the clinical pictures that these patients show and the clinical features we are confronted with when taking care of these patients. So let me now try how I get through my slides, because that doesn't seem, yes, okay. So autoimmunity, it is, when we look at it now, it seems to us it's a very realistic. It's a hot topic, and it can be a surprise that even as little as a little over 100 years ago, it was considered completely crazy, unacceptable, unthinkable, as Paul Ehrlich said, that something that meant that our own immune system, that is exactly trying, that in its role is supposed to defend us, that we are being misguided, cheated on by this very system that is supposed to protect us. This was considered horror autotoxicus, and in the beginning of the last century, it was considered impossible that our own bodies would cheat on us and hurt ourselves. However, this was contradicted by many clinical observations that followed in the first half of the 20th century, in which an increasing number of clinical observations were brought back to the mechanism of antibodies that were produced by the body and that were actually harming our own cells. So that was a case in paroxysmal nocturnal hemoglobinuria, which is easier to say in Dutch, or thyroiditis is inflammation of the thyroid gland. Both were observed to be caused by antibodies directed against red blood cells or the thyroid gland. And so in the mid of the last century, the clonal selection theory was proposed, stating that autoimmune diseases, for one, they do exist, and that was already a game changer, and that it must happen because the fact that there are that antigen receptors somehow acquire somatic mutations during life. They will start to recognize and target self or our own organs, cells, or systems, and that these forbidden clones that are actually attacking our own bodies, that they are not deleted during specific selection processes and continue to exist and are able to attack the human body and cause autoimmune diseases. it is so that the distinction for our immune system, and I'm happy that I am sure, and also I have already had a little glance, that the speakers that come after me, they will also go into far more detail on this than I am, because as I said, I am a clinician at first. But the principle of autoimmunity is the failing distinction of our immune system between foreign, which it is supposed to attack if we are attacked by viruses, bacteria, or external agents, and self, which is actually serving to protect or should protect. So the distinction between foreign and self, that is it's a prime function of our immune system, but it's not absolute. It's not. There is a notion of a low, let's say, physiological level of self-reactivity of our immune system that is present in the human body. There is an intermediate level of autoimmunity in which we can observe that there are autoantibodies circulating, and that can be detected on common lab tests that we perform in clinical practice, but that there are antibodies present, but that the clinical consequences for the patient seem to be absent. So that is a concept in clinical, that's a clinical reality that we see healthy patients, healthy persons without any symptoms or any damage, in which commonly performed lab tests do detect autoantibodies. And then, of course, and that is where it becomes clinically relevant, the end of the spectrum in which this autoimmune phenomena, so the failure of discriminating self from foreign, results in immune-mediated organ injury, in which we're talking about autoimmune disorders. This, I will go short, very short over this actually, because this will come back in presentations later, and I will maybe already put the next part of our immune system. We have, and that's the way I explain it to the patients in a sense. You have our innate immune system, which is it's very robust, it's very aggressive. It's our first line of defense upon an attack, which can be viral or bacterial or any other pathogen. It's a very non-specific, both cellular and humoral immune response, that it provides an immediate immune response, but it's non-specific. It's driven by specific immune cells, including macrophages, natural killer cells, neutrophils, among others, but it does not provide an immunological memory. And I will try, I'm not sure if you can also see, and that I will try to correct now, because I can see myself, and I assume that you can then also see me just for a second in the presentation part. Okay, and now I should be gone. Is that correct? So, okay. Whereas the adaptive immune system, it is a more sophisticated part of our immune system. It's only present in vertebrates. And that is the part of your immune system that enables immunological memory. So when we first encounter a pathogen, the adaptive immune system will be responsible for a more mature and enhanced immune reaction afterwards upon a second encounter, and that includes a totally different type of immune cells, so T cells and B cells, and the production of antibodies directed very specifically to the pathogen that has been encountered once. And so upon the next encounter, we can get a directed and a fast response based on immunological memory. Now, both actually, both innate immunity and adaptive immune system should be, and the immune responses resulting in inflammation should be temporally and spatially regulated and, very importantly, attenuated. It is not of any benefit that when we are attacked by a virus or a bacterium, that these overwhelming inflammatory responses occur for one, but then are not down-regulated and come to an end. It's these kind of over-inflammatory or hyper-inflammatory states is, for example, also something that is present in what we see in COVID and hyperinflammation in a COVID infection, for example. So if the immune response is not down-regulated and terminated or regulated, this results in pathology, in persistent pathology. And so the uncontrolled activation of the adaptive immune system, in which T cells and B cells are autoreactive and are actually reacting to proteins, to self proteins or cells of the human body itself. In that case, we get the development of classical autoimmune diseases. So in autoimmune diseases, we see a loss of that immune tolerance towards self. We get the recognition by antibodies or by TMBs of self-antigens. We get specific antibody, auto antibody production. And when these autoantibodies and this inflammatory state, it will cause organ damage caused by this dysregulated adaptive immune response. It is very important when we talk about and now I'm coming into my field of expertise in which I'm feeling very comfortable, which is autoimmune diseases. When you name it like it seems like one title and one topic, and it is not at all. It is autoimmune diseases is a title that covers a very broad spectrum of pathology. Autoimmune diseases in the literal sense, in which the pathology is driven by maybe an adaptive immune system response targeted towards itself, has a very high prevalence. It will affect almost a little, just 79% of the total population. It will primarily affect women, and it will affect people in the active population. So between 40 and 60, that will be the median. And it's associated with relevant morbidity and mortality. Of course, we all know when we're talking about almost 10% of people suffering from autoimmune diseases, it is clear that when you look around you, that not 10% of your family and friends are suffering from the same type of disease, or all have a very serious disease. And this immediately points to the clinical heterogeneity of autoimmune diseases. And one very specific concept, or really important concept, is the fact that this autoimmune response or mechanism, it can attack in an organ-specific way. For example, such as is the case in type 1 diabetes, where the pancreatic cells are affected, or in Hashimoto's thyroiditis, where the thyroid gland is affected, or specific neurological autoimmune syndromes, such as multiple sclerosis. And then, so that organ-specific autoimmunity versus, and that is my clinical field of expertise, the systemic autoimmune diseases, in which this autoimmune activity or self-reactivity is targeting multiple organ systems, such as at the same time often, and the skin and the joints and the skin, joints, renal function, lungs, etc. Examples of these systemic autoimmune diseases, which I will give you a clinical introduction to in this presentation, is lupus, rheumatoid arthritis, or Sjögren's syndrome, for example. Characteristics of autoimmune diseases, in my opinion, it's clinically very heterogeneous. So it's makes no clinical sense to just use autoimmune disorder, because then you will cover a very broad spectrum. The sex bias, the polygenic nature, and the multifactorial contributions of genetic and environmental factors, on which I will be very short, because it's a topic of the presenters that will follow me. So the clinical heterogeneity, I am repeating this, but it means, and I will show you some very clear case vignettes in this presentation. That is, of course, at first, there's already a difference if somebody has a single organ manifestation, such as autoimmune thyroid disease, versus these lupus patients, for example, or systemic sclerosis patients, in which many organs are affected at the same time. Then secondly, there is a difference in the time course of disease presentation. For example, type 1 diabetes, so you have the pathophysiology of autoimmunity, including, and I will not go into detail, in a genetic background, and then probably a second hit from environment, probably altered immune function, the arising of autoimmune, autoantibodies and autoimmune response. And then, for example, in some diseases, and mainly the ones that I am seeing in my daily clinical practice, patients present at this time, in which we can already see the autoantibodies and the immunological activity, but so far, I see them in the beginning of the active phase, and the structural damage that will destroy joints or destroy renal function will come later on if we do not treat the patients well, because it can lead to organ failure, for example. But in type 1 diabetes, for example, patients will present when the organ, the structural tissue damage has already been done, and you have the failed insulin secretion and the diabetes as a clinical sign. There's also a complete heterogeneity in the therapeutic responses. I think it's also very important to recognize and to realize that autoimmune disorders are characterized by, indeed, this phenomenon of autoimmunity, but the different diseases will differ in their main pathogenic, they will have a different cytokine profile, different cell types which are primarily active, different types of inflammation in the organs or tissues that are affected. And so, for example, this is only for rheumatology, but it is not the case that every patient will benefit from TNF-alpha blockade, or that every patient, across diseases, will benefit from IL-17 targeting. So there's definitely a heterogeneity, both in clinical presentation and also in therapeutic responses across the different autoimmune diseases. Sex bias, in which we can be short and say that it's primarily females who are affected, is a common denominator of the majority of the autoimmune diseases. And it can be very, very clear in some, such as lupus, systemic lupus erythematosus, in which it would be up to 9 females for 1 male. It's the same in Sjögren's, and also systemic sclerosis is a very female predominant disease. But so the sex bias favoring, or let's put it the other way, primarily affecting females is common in autoimmune. It's a common denominator. I will be very short on this because it's a topic of the third speaker, I think, on the genetic background. I think it's very important. It's something that in clinical practice we need to explain to our patients, because the question on how did I get this, and am I supposed to test my children, and what will I tell my children? The reality is that there are some, but it's very rare, that autoimmune diseases have a monogenetic pathophysiology. It is the majority have a polygenic nature, and it will probably be the additive effects of several risk variants, each with small effect sizes. But I will skip this slide to leave this to the speaker that is specifically focusing on this topic. We do believe, and that's why, and I think it's not, I did not invent it, but I love it, that genetics load the gun and environment pulls the trigger. It is probably true, although, and I truly believe in this. But I think many questions arise or still present on, and which factors and when in life, and how does this work? Because these are the questions that patients are asking me. So I'm very excited about all these initiatives, because they will all, hopefully in 5 to 10, or I don't know how optimistic I can be or should be, provide me the answers to give to my patients. I think it is also important for all of us to realize that autoimmune diseases they carry a high burden of costs to society. So the top drug spends are spent in oncology, in autoimmune diseases, and in diabetes, and there is a vast increase and continuing increase in the drug spent, and continuing growth in the drug spent in autoimmune diseases. And so we can, for one, think, okay, we all have a lot of money and a lot of great drugs that are still coming. On the other hand, I think the whole goal of this this work that we are all doing is hopefully trying to get an idea on what is the cause and be able to really prevent disease. That would be, of course, the ultimate goal. So I want now to take this second part of the presentation to guide you to some clinical images of some of the diseases that I treat in clinical practice, because it seems, again, homogeneous systemic autoimmune rheumatic diseases already, and it is very heterogeneous in nature. And I want to guide you through some clinical vignettes, hopefully demonstrating this to you. So the first case is a 21-year-old female patient. And so a female patient that presents to the consultation. So it's a young female, and she is suffering from increasing joint pain. She says, I'm so stiff in the morning. Normally I go to university, or I go to, and I sport a lot, and I'm very active, and I used to go out, and this, since for a couple of weeks, 3, 4, 5 weeks maybe, I just cannot get out of bed. My hands hurt. I'm really stiff, and there are some swollen joints that you can see on her fingers, which I can show here with my pointer. And in the morning, I can hardly close my hands. It hurts, and they're swollen, as you can see. And actually, doctor, it's a little bit better now in the afternoon, because it's afternoon, but in the morning, I can hardly get out of bed. She also has a new skin eruption on her face, and she says, yeah, it came when we were on holiday, when in our sunny holiday, just all of a sudden appeared. When you go through her lab test, you see that she has multiple autoantibodies, antibodies directed against double-stranded DNA, anti-SSA antibodies, anti-SSB, anti-Smith antibodies. So multiple autoantibodies are present. And surprisingly, and actually very worrying, I already see that her renal functions decrease, and she's losing a lot of protein in her urine. This is the classical case of a young female presenting with a new onset of systemic lupus erythematosus. Systemic lupus is the queen bee of the systemic autoimmune diseases, in my opinion. It is not a rare disease. So in Europe, around 100 cases, 50 to 100 cases per 100,000. And why is it the queen bee? Because when we're talking about systemic autoimmunity, autoantibodies, systemic, affecting different organ systems, well, lupus has it all. In the lab test, we can observe specificities directed against self proteins, against most often 3, 4, 5 different specificities in high titers. Lupus can manifest in almost every organ system. Classically, it will involve the skin and the joints. And these skin lesions, which you can also see here, will be UV sensitive, will be triggered by UV exposure, so sun exposure. And sun exposure can trigger the onset of lupus and trigger the activity. And so the predominant complaints in the beginning are skin rashes, joint pains, joint swelling. So it's not the type of joint pain that says I'm hurting because I had just had 2 days of cleaning my whole house and that's why it hurts. No, they get up in the morning and they cannot get out of bed because they're all stiff. They often have some general complaints like weight loss, low-grade fever, fatigue. But lupus carries an intrinsic and a high risk of organ involvement, and some of those organ involvements can be clearly dangerous. And at one, we are afraid of the renal involvement. So if not recognized and treated aggressively, this will lead to renal failure and dialysis and sometimes permanent renal failure and in need of renal transplant. But you could also see central nervous system involvement, etc. The treatment is sun avoidance, which is easier to say than done. They need very dedicated UV protection, so factor 50 to 100 changed every 2 to 3 hours, combined with immunomodulators and immunosuppressants. These are young females that we are diagnosing with an potentially severe disease. Of course, when you treat them well, follow them well, and there's heterogeneity in the course of the disease. We also have mild lupus, but they are at risk of the severe involvement. This is a chronic disease in need of long-term treatment. So this is lupus. The second case is a completely different manifestation. This is a 44-year-old, but I could have also said she's 55 or 60, but that would not have fit the picture that I'm using, but it's a female patient again, presenting to your consultation, and her primary complaint is, I have dry eyes. In the morning, I cannot get my eyes open when I'm in the shower. It hurts, it hurts. My mouth is is extremely dry. You can see her tongue here. I have to drink all the time. I cannot even talk on the phone without drinking 3 to 4 times. And as you can see, doctor, there is these, I look like a hamster. I have these swollen parotid salivary glands, and also my joints also hurt. There's also this morning stiffness, and I'm really tired. Again, in this female, presenting primarily with the dryness and the swollen salivary glands, you also find autoantibodies. You treat her, and I will shortly discuss how, but then 2 years later, she's diagnosed with a lymphoma, which is luckily treated well, and she's still in active follow-up. This is primary Sjögren's syndrome. Primary Sjögren's syndrome is even more frequent. Generally, it's the prevalence is like it's around that of lupus actually, but it's more frequent in the middle-aged females between 40 and 60. And in this disease, which is also a systemic autoimmune disease, but the primary attack is against the exocrine glands. So you will have the problem of dry eyes, dry mouth, but also dry throat, vaginal dryness, skin dryness. So primarily affecting middle-aged females, and with a very wide range of severity. And the majority of the patients will suffer from the dryness and the fatigue, and that's about it. And we will have to try to manage that with lubricants, etc. But there's a 10% lifetime risk of developing lymphoma because of the continuous activation of the immune system and the activity of the immune system. And so we will also have patients that develop lymphoma, but you can also have severe immune-mediated lung or renal disease or neurological manifestations in Sjögren. So it is a clinical challenge to follow up these patients and to discriminate those patients and to timely detect when patients are evolving in a negative way. In that case, so with organ manifestations, we will need to use immunosuppressants. The third case.
Sorry, Ellen.
Yeah.
How long do you still think you need? Because we are at 34 now.
5 minutes, 4 minutes.
Yeah. Okay.
Just this one is the 9-year-old male, and that is interesting. It's a male construction worker, and he presents with Raynaud's phenomenon, so discoloration upon cold. He has a tightening of the skin, and he's short of breath. And he has other antibodies in his lab test, and he already has lung fibrosis. He's treated very aggressively with immunosuppressant, and he dies 2 years after disease onset. This is a case of systemic sclerosis. Systemic sclerosis is the most severe of the connective tissue diseases. It's rarer than the ones before. It's female predominant, but it is definitely associated with environmental exposure to respirable silica. And it has a higher mortality of all the connective tissues. Has to be treated aggressively, immunosuppressant and/or transplantation. I will skip this one, and then go to the last one, because this is a case description in which the immune attack primarily affects skin and muscles. So this is dermatomyositis or the myopathies, very rare and often associated with underlying cancers. Last one is, and I do want to talk about this one because this is actually a very prevalent disease and also a systemic autoimmune diseases. This is the 51-year-old female, again with the swollen joints, a clear inflammatory type of pain. She cannot, she works with a hairdresser, but she needs to stop. And you tell her, you carry rheumatoid factor and anti-CCP antibodies. You have rheumatoid arthritis. You urgently need to start anti-rheumatic drugs, but she sadly never returns to your consultation. And you see her on a private matter after 15 years, and the patient's joints look like this, totally distracted, complete loss of function. This is rheumatoid arthritis. This is the prototype of the chronic autoimmune inflammatory arthropathy, primarily affecting the joints, but it can also affect the lungs, for example, with a prevalence of almost 1% in the European population. And this is an inflammatory disease that will, when not treated timely and correctly with anti-rheumatic immunosuppressive drugs, result in total joint destruction. So the case that I want to make is autoimmune diseases are prevalent, affecting up to almost 10% of the global population, but there is a very heterogeneous type of manifestation. The manifestations can be very heterogeneous, even within the group of systemic autoimmune rheumatic diseases. We can have diseases primarily affecting skin, lungs, joints, muscles, and that makes the clinical treatment. So I think it is very important that that clinicians dealing with these patients are aware of the heterogeneity. And I think I wanted to ask you all, please help us indeed in unraveling the pathophysiology, getting an idea on what drives these diseases, and hopefully we can go for prevention and better targeted therapies, because I think in many of these diseases, these are still lacking. Thank you for your attention.
Thank you very much, Helen. It was very, very interesting, and yeah, some scary photographs now and then, but yeah. So I've got a few questions here. I will ask one, and then I suggest that I send the other ones to you that can be maybe in written be answered, because you have to leave. That is why. Mm-hmm. And we're also running out of time. But why is it known why women are more prone for these diseases? Is this hormonal? Is it X chromosome, or is it just not known?
It is still not fully known. It's not fully known. There are hormonal effects, and we also have some clear observations in which we see, but let's say, in which we see the disease appearing during pregnancies, in the postpartum periods. But on the other hand, some autoimmune diseases are known to get better during pregnancy. So even the hormonal effects on the different immune diseases are heterogeneous. So I'm not fully into this domain specifically. So if anybody else is, please correct me. But as far as I know, it is still insufficiently known what is really driving this sex bias. But I'm not the expert on that topic. Sorry.
Okay, thank you. But yeah, for sake of time, we have to go on also. So thank you very much for this very interesting overview of the most common, let's say, systemic autoimmune diseases, and having really a picture of what it really means clinically. Thank you, Ella. Okay. And so then we come to the next speaker, and I will put my camera on again. You can see me. That is Dr. Signe Hjuler Boudigaard, and she will talk on occupational exposure to respiratory crystalline silica and the risk of autoimmune rheumatic diseases. She's from Aarhus University, and her domain is logically on the title, maybe occupational exposures and immune diseases. So please, Signe, take the screen and start your presentation.
Let's share it now. So I think it should be here now.
Yeah.
Perfect.
Okay.
Yes. Well, thank you for the opportunity. I would like to talk with you, share with you a study that I've done together with a group of colleagues on occupational exposure to respirable crystalline silica and the risk of autoimmune rheumatic diseases. So the autoimmune rheumatic diseases that we have looked at is systemic sclerosis, rheumatoid arthritis, small vessel vasculitis, and lupus erythematosus. I think a lot of the diseases have been presented here already, so I'll just briefly say that these diseases are, of course, different diseases, but they do share some common traits. I mean, they have different clinical manifestations, as you just saw before, but they are all rare diseases affecting. These diseases do affect around 1% of the population. They're most common among women. There are a high comorbidity between these diseases, and also there is the age, like just said before, that they peak around 40 to 60 years of age. So I won't say much more about it. Just briefly also on the mechanism, we still have a lot to learn about the mechanism behind these diseases, it has been suggested that a number of triggering events in susceptible persons can lead to first physiological autoimmunity and later on clinical diseases in some, like it was stated just before. These triggering events, it could be the inhalation of fine particles, as you can see here on the figure, where they are taken up and deposited in the lung, taken up by the alveolar macrophage, where they result in a cytokine production that causes an inflammation and an activation of the immune system. Later on, these macrophages, they will undergo apoptosis and they will burst, and the content will be released and it can be taken up again, resulting in a more chronic stimulation. And also these cells of the immune system, they will leave the lung and go back into the systemic doing their effect. And at some point, as said before, they can become also reactive. And then you have the possibility of a systemic autoimmune disease. So that was just very briefly. When it comes to risk factors, there's still a lot we don't know. The genes, as it was said, does mean something. But in studies of monozygote twins, it has been shown that the concordance rate are quite low, between 10, 15, up to 30%, meaning that there must be something else that also matters. Smoking is a well-established risk factor for rheumatoid arthritis, but we don't know for the other diseases that I mentioned. And then there could be occupational exposures. Almost 100 years ago, it was suggested in a cohort of silica exposed workers that they had a higher mortality due to rheumatoid arthritis. Later on, in the 50s, 60s, and 70s, a number of studies came showing a higher incidence of systemic sclerosis and rheumatoid arthritis in high silica exposed workers. And like it was said before, the audience are a bit different in their experience. Some are very interested in the clinicians, and some are more for the epidemiology. So I'll just say something brief about the silica exposure, or the respirable crystalline silica. It is found in the earth crust, in sand, soil, and stone, and it's a major part of the earth crust. It has the chemical formula silicon dioxide, and it can be on an amorphous structure or a crystalline structure. And when it's crystalline, it will look like this. Of the crystalline structure, quartz is the most common. Workers worldwide are being exposed in, for example, mining or quarrying, or in the manufacturing of metal products, as here from an iron foundry, or in the, you can say, manufacturing of stone products. This is a stone cutter, and especially in construction, where products either directly from sand and stone or products made out of it are being handled and proceed in different ways. A number of studies has been shown a yearly decreasing trend of exposure levels to this, to respirable crystalline silica, but still it's a major risk factor for workers worldwide. When we look at the literature on respirable crystalline silica and these autoimmune rheumatic diseases, we see a number of studies shows an increased risk of rheumatoid arthritis in men. Few of the studies have included women. And for the other diseases that I mentioned, there are either few studies or the results are more inconsistent. So we still need more knowledge on the association. Then the studies have limited quantitative exposure information, and we do not know much about the exposure response relation. Finally, we still need to know more about time windows of exposure. So the hypothesis behind this study was that occupational exposure to respirable crystalline silica increases the risk of autoimmune rheumatic disease in a dose-dependent manner. And we aimed at examine this in a cohort study of the entire Danish working population using a quantitative job exposure matrix. And this is the structure behind our study. We have a cohort, we have outcome and exposure and a timeline. And I will go into detail with each of these elements. Starting with the cohort, we use the DocX cohort. And the DocX cohort is a cohort of all Danish residents ever employed in the period between 1976 and 2015. That is roughly 6 million persons. In the cohort, we have annual information on occupation for each resident. And we have information based on registers that will be registers on civil registration, but also registers on employment classification. And in those registers, we have the information comes from tax records, from the employer's mandatory reporting, and also other sources. In our study, we included only workers born after 1956 in order to have full occupational history on all the persons in our study population. That means that we ended up with a study population of 3 million persons. Then for the exposure assessment, we each worker or each person in the cohort were assigned an annual exposure level of respirable crystalline silica based on their annual occupational code. And this code is from the DocX cohort, and it is coded in ISCO 88. That is the International Standard Classification of Occupation. And together with this, it was combined with the Signe Job Exposure Matrix. The Signe Job Exposure Matrix is based on more than 20,000 historical silica measurements collected from workplaces all over, not all over, but from several European countries and from Canada, and combined with expert assessment. And the Signe gives job, calendar year, and region-specific estimates for each of the job codes in ISCO 68. So in order to do this study, the Signe was converted into ISCO 88. And just for those who are not really familiar with working with the job exposure matrix, I have this figure here, and you can imagine a job exposure matrix like a big cube or a matrix where you have different kind of axes, and you take out each of these small blocks and you will get the information. So for instance, in year 1988, if you're working as a stone cutter, then you will have a mean exposure level of 602 micrograms per cubic meter year. And this is assigned to the person in that year, and etc. So finally, we had the outcome assessment, and we had information on outcome from the Danish National Patient Registry. That in Denmark, all patients in contact with the hospital will have a diagnosis, and that is coded into ICD-8 or ICD-10, depending on the period. And this register, it was introduced in 1977 and has been updated ever since. In order to avoid or to only include incident cases, we introduced a 2-year washout period. So if we go back to the structure, then we will have the DocX cohort with the Danish working population born after 1956, resulting in a study population of 3 million persons, corresponding to 65 million person years. And we have outcome from 1979 until 2015, and exposure information from 1977 until 2015. And this was based on their annual occupational code and the Syndium. So we follow each study member from the time they enter the labor market until the event of disease, death, immigration, disappearance, or end of follow-up. For statistical analysis, we did all statistical analysis as discrete time hazard models, doing logistic regression with person year as the unit of analysis. And that gave us incidence rate ratios. We stratified all analysis by sex because the diseases are most prevalent among women, but the exposure are most prevalent among men. So in order to avoid mix-up, then we stratified. And then we adjusted all analysis for age and calendar year. Then we did a number of sensitivity analysis, one where we adjusted for tobacco smoking using a smoking job exposure matrix that was developed for DocX. And then one where we adjusted for the highest educational level. And finally, one where we restricted our cohort to those who were working as blue-collar workers at baseline. We looked at a number of different exposure metrics. That would be cumulative exposure, duration of exposure, mean exposure intensity, and highest attained exposure intensity. And we looked at exposure in different time windows. In this presentation, I will only show you the cumulative exposure and also the exposure from time windows. Now for the results, I would start to share with you the exposure distribution. This is a cumulative plot of the distribution of cumulative exposure in the follow-up among 260,000 men and 40,000 women. So men are more often exposed than women. And if you look down here on the x-axis, we have the cumulative exposure level in micrograms per cubic meter years, and up here on the y-axis, we have the percentage. The blue are men and the red are women. And as you can see, men are not only more often exposed, they are also exposed at higher levels than the women. Looking at incidence ratios of all the autoimmune diseases, this rheumatoid arthritis, systemic sclerosis, lupus, erythematosus, and small vessel vasculitis combined, following accumulated respirable crystalline silica exposure, we get this figure. And just briefly on how this is, how to look at it. Here on the y-axis, we have the incidence rate ratio. And down here on the x-axis, we have the exposure. And this is the cumulative in micrograms per cubic meter year. We have the blue is for men and the red is women. And if we look here for the men, then it's grouped into four: the unexposed, low, medium, and high exposed. And the unexposed is, of course, the unexposed, but these three groups are divided by the tertiles of total exposed person years. And what you see here is that, especially among men, but also among women, there is a exposure response association. So the higher you are exposed, the higher the risk of having one of these diseases. If we look at the trend then, so that would be the increase per 50 micrograms per cubic meter year among men, then we see that it will correspond to a 7% increase. That is if we look at all the men. If we look at the exposed only, like in an internal analysis, then it will be only a 3% increase per 50 micrograms per cubic meter years. And for women, as you can see, it is a bit lower. Then we looked at the exposure, not grouped, but the categorical, in looking at cubic splines. And what you see here again is that with increasing exposure, we see an increasing risk. This is most obvious for men. For women, when we go beyond 100 micrograms per cubic meter a year, there are not many women exposed, and the results become uncertain. But before that, it looks like it's increasing as well, just like here with the men. Then we look at the diseases separately. That is interesting as well. We have systemic sclerosis, rheumatoid arthritis, lupus erythematosus, and small vessel vasculitis. And what you see is for especially systemic sclerosis and rheumatoid arthritis, we see increasing risk with increasing exposure, both for men and for women. For systemic sclerosis, the confidence intervals are quite wide, but we also have a few cases. Looking at systemic lupus erythematosus and small vessel vasculitis, the results are a bit more uncertain, but I would still say that there is a tendency towards the same pattern, most clearly among the men. So that would be for the different diseases. Then we look at exposure in different time windows, and briefly on how we did this, because I think people understand this a bit differently. If we look here at time 0, then we can go back into different time windows. And if we look at, for instance, the time window 11 to 20 years ago, then we will only take into account the exposure received in this time period. So all the exposure received here and here will be disregarded, and we will only take this into consideration. And here you see the result from the cumulative exposure received in the different time windows for all the autoimmune rheumatic diseases combined. And you see that we have, again, blue for men and red for women. And we have the unexposed, and then we have the two exposure groups dichotomized, so that it will only be in two groups. And we have, and if we look at it, this is the window of 1 to 10 years time window. This is 11 to 20 and more than 20 years time window. And you have to go down here in order to have a clear exposure response association. So looking at this, it looks like that the exposure received more than 20 years ago are the most important for this association. So rounding up, I will just briefly touch upon the strength and the weaknesses in this study. I think, first of all, we had a large population and a long follow-up time, which actually makes it possible to look at these rare diseases in this way. And also, we were able to use register information, and that is from registers with high coverage. We have a public healthcare system in Denmark with free access for all inhabitants. And also, we have annual information on occupation and also employment status. And we were able to use a specific and quantitative job exposure assessment, or exposure assessment using the Signe job exposure matrix. When we use a job exposure matrix, this assigns group mean values to all individuals that potentially cause non-differential misclassification of individual exposure level. However, this should mainly be affected by the Bergson error, meaning that it has little or no attenuation of the risk estimates. So I would say that these two things, using the registers with high coverage and the use of the Signe, would largely limit the risk of selection bias and also recall bias. However, looking at the weaknesses of this study is the risk of potential misclassification bias in the modification of the GEM. The GEM, as I said, was designed for ISCO 68, and it was converted into ISCO 88 for this study. And that could, of course, introduce some kind of misclassification. Then there is the diagnostic classification of the diseases. These diseases, as it was said half an hour ago, is they share a lot of symptoms, and it can be difficult. It can be time consuming to make the correct diagnosis, and it can take some time. Some studies have shown that the positive predictive value of systemic sclerosis, when you compare the diagnosis in the register and to medical journals as a golden standard, then it's 95%. So that is quite high. But for the other diseases, it's only around 75%. So there is a risk of misclassification bias. It should not be related to silica exposure. And I would believe that it is non-differential misclassification, and it would bias the association toward the no. Then there is the risk of potential confounding. We did stratify on sex, and we adjusted for age and calendar year. However, there is still the risk of smoking and other socioeconomic factors affecting our results. As I said, we did sensitivity analysis where we adjusted using a smoking gym, a smoking job exposure matrix, and also adjusting for highest educational level, and one where we restricted our population to blue-collar workers only. So this should take these into account. When we looked at the results, they were quite similar to the results that I have presented. The risk estimates were a bit lower, but the patterns were the same. Then there could be other risk factors that we simply are unaware of, and that we, of course, by that haven't taken into account. That could be lifestyle risk factors or other occupational risk factors. Anyway, when we look at the study, the results, the strengths and the weaknesses, and wanting to conclude, I would say that this study suggests that respirable crystalline silica do increase the risk of systemic sclerosis and rheumatoid arthritis. And it also likely increases the risk of lupus erythematosus and small vessel vasculitis. This is most evident among men. However, there are few exposed women. We find that there is an exposure-response relation, and that the highest risk is seen following exposure received more than 20 years earlier. Coming to the perspectives of what we will look into in the future is what is the effect of high exposure versus long-term exposure, and if there are susceptible periods in life that you're more vulnerable to silica. If silica is exposed, if silica exposure is associated with specific biomarkers of diseases, that would be specific autoantibodies. What the excess lifetime risk at different silica exposure level is, and then finally the joint effect of silica and other exposures. Thank you.
Thank you, Signe. A very good overview of a very large study, to be said. I've got here a few questions. It's a bit more mechanistic, but it's really something that probably everyone is wondering, because it is what is about the onset of the mechanisms of silica-induced autoimmune diseases and other pathologies such as silicosis. Are they related? Are they overlapping? Or maybe it's, that is more detailed mechanistic, and you did not cover that, but anyway.
I actually must say, I'm sorry, I don't know. It would be, how do you say, this, for instance, the silicosis, that is an inflammation of the lung, while it is likely that the inflammation of the lung also triggers some of the same cells that are involved in the autoimmune mechanism. As it was presented before, probably it's different kind of genes involved, and also different kind of triggering events. But as far as I'm aware, there are not a one-to-one relation. So, but I'm sorry, I don't have the answer on that one.
No, but that's yeah. I think maybe we come to that later on in different talks. I guess that also oxidative stress and epithelial cell that could play a role in this. Another question is you crystalline silica and you said quartz. You did not measure it, but is it known from other types of silica, crystalline silica, if it also induces similar disease patterns?
Well, other kind of silica is associated with other diseases, so it would be likely that it could also affect this. But in this study, we have included the quartz as the silica exposure. So again, I don't know, and quartz is the most common, so that is what is most well known.
Yeah, it is probably difficult in a database as you have to trigger that out to find out which are the different types of silica people are exposed to, I guess. Yeah.
Yes, I'm sorry.
Okay, no, very interesting. Thank you for your contribution. And then, because also for sake of time, I think we have to go to the next speaker. And I've put my slides up here again. So this is our next speaker is Dr. Michael Pollard from Scripps Research Institute in the US. And he is mainly interested in mechanisms. So maybe we get some answers on the questions we had already. Of systemic autoimmune diseases, and he's developing models, animal models, to do these studies. So, Michael, I will give you the screen so you can put up your slides.
Okay, great. Thank you, Peter. So hopefully everyone can see this.
It's coming, yeah.
There we go.
But it's not in presentation. Yeah, now it is. Thank you.
Yep. Should be okay, yeah. And the laser pointer. Okay, so yeah, thank you, Peter. It's a pleasure to give a talk to this group, obviously a very large group. So what I want to do today is a little bit different. I'm going to talk mainly about the work that we do, which is almost totally focused on animal models and development of animal models, specifically for autoimmunity and also the role of environmental exposures in the induction or exacerbation of disease. And so what I want to address, some of these topics have been sort of addressed in the previous couple of talks, but I want to go over these as they relate specifically to developing models and also to sort of outcomes that we see in these models. So I want to talk a bit about this sort of subclinical or early evidence of autoimmunity and the difference between that and actual clinical autoimmune disease. Then a bit about how we sort of think about experimental models that we actually develop and how the responses to environmental exposures are studied in some ways. And then look more in detail at two particular exposures that we've worked at. One of these is mercury exposure, which produces a subclinical autoimmunity. We've worked on that for a long time. I'll talk briefly about that, and then I'll talk a bit more about the new model that we have looking at crystalline silica exposure and autoimmunity in an outbred mouse model. So this was sort of discussed by the first speaker. I just want to elaborate a bit more on this. This idea of subclinical versus clinical disease differences is, I think, very important because we know now from the study of numerous idiopathic autoimmune diseases that actually these subclinical features or sort of autoantibodies and various inflammatory cytokines can occur actually many years before the actual diagnosis of a specific autoimmune disease. This occurs in many different diseases, rheumatoid arthritis, lupus, diabetes, and so forth. In terms of environmental exposures, what we know in sort of reflection of this is that there are a large variety of different factors that have been shown, some in human studies, most often in animal model studies, that you get evidence of these autoantibodies and inflammatory markers occurring, not necessarily associated with disease. And obviously one of the best models that we have of this is the exposure to heavy metal mercury. As was studied now almost a decade, well, it is a decade ago now, really a large study looking at the sort of relationship between exposure and autoimmune disease and identifying what may be confident linkages between exposure and disease. There really are only a few exposures that are confidently linked to the development of autoimmune diseases in humans. And as we've heard, the most prominent among these are really smoking and silica dust exposure. And one of the problems with identifying or at least establishing an association between humans and environmental exposures really is that linking these types of associations is extremely difficult. There are many sort of confounding factors involved in this. For example, humans as a population are rarely exposed to a single agent over time. There can be, in some cases, huge delays, as we've just heard, huge delays between actually the long-term exposure versus the onset of disease. And then there can also be big differences in the intensity of the exposures or the actual length of the exposures. And both of those can actually influence the severity of a response. And then, of course, there's this underlying genetic predisposition, which may lead some people to develop disease earlier or more severe disease than others with different genetic background. And we can overcome pretty much all of these limitations by using animal models. We can control exposure sites and doses and times of the length of exposure, the age of the animals and sex, and also their genetics. And this also gives us a greater ability to actually identify the possible pathogenic mechanisms of these exposures. But one of the other sort of issues that we need to think about when we're doing these sort of exposure studies is that are we actually triggering a de novo response in healthy individuals when we expose them to a environmental exposure? Or in fact, are we actually exacerbating or accelerating disease in individuals that actually have an underlying idiopathic autoimmune disease? Or is it a mixture of the two? Are we actually able to exacerbate or accelerate idiopathic disease, as well as also causing a specifically induced response to this particular environmental exposure? So there are many different things that we need to think about when we're trying to study the relationship between exposure and disease in animal models. And these also, of course, reflect on the human experience as well. So there are really a large number of ways to use these models to look at environmental exposures, and we've used pretty much all of them over many years that we've been doing this. Obviously, one way is to take non-autoimmune prone or healthy mice and expose them. It's essentially an induction model. The other way to do this is to take autoimmune prone strains of mice. These are mainly lupus prone animal strains. This is essentially an exacerbation or acceleration model. Then you can take genetically modified animals, either with a gene knockout or a transgene added and so forth, and essentially look at the genetic dependence of the phenotype following exposure. And most of the studies that have been done in the past have used inbred mouse strains. And the reason for this is very simple. You get a reproducible outcome within a particular strain. One strain will respond pretty much almost the same. And that's because they have the same genotype. But the problem is that sort of usage really gives you a genotype of N of 1 per strain. So it's very limiting unless you study many hundreds of different types of strains, which is an extremely expensive and time-consuming process. The other thing that's now come to the fore to sort of answer that particular question is to use outbred strains. These are much more diverse genetically. A big problem with them, however, is that you can't really modify them genetically very easily, but they're particularly useful for exposure studies because you're exposing a very diverse genotype, and the exposures can be done very easily. So moving on to these two exposures, with the mercury exposure, we've studied this now for many years, and we've used a wide variety of different types of invert strains. We used healthy strains, we've used lupus-prone strains, and we've used many, many different genetically modified mice. And in essence, these responses pretty much mimic what you can follow, what's been observed in human populations. So there's evidence for inflammation, there's evidence for antibodies, and there's also evidence for kidney damage in the mouse, and that's essentially the same as the human. And with these studies, we've also been able to show that there are effects of the genotype, there are effects on the inflammatory responses, autoantibodies, and pathogenic requirements of this type of autoimmune disease. And really, to save time, I'm just going to cover two or three more slides in this particular area. Basically, in humans, the exposure to mercury is an occupational exposure. It can be also dietary. There's also various therapeutic and cosmetic agents that are used. And the exposures are really linked only to markers of inflammation and autoimmunity. And these exposures that have mainly been studied for autoantibodies, for example, are gold mining, where people are exposed to mercury vapor, or, for example, fish consumption. And a lot of these studies come from South American populations. The evidence for kidney damage due to mercury exposure comes primarily from the use of skin whitening or skin lightening creams. And this is particularly prevalent in countries where folks have darker colored skin. It leads to a nephrotic syndrome, membranous nephritis, and it can also be associated with autoantibody. But as we've learned over many years of us and others studying this, there really is no linkage of mercury exposure to an autoimmune disease per se. But what we do know from the vast majority of our work is that, in fact, it all comes down to this one slide, and that is that you have a progression of disease processes, or pathological processes, if you like, which really encompass a whole variety of different aspects, and they begin with an initiation, which essentially is a toxic result of exposure leading to cell death and proteolysis of cellular constituents. That leads to a localized inflammation, which essentially is really an innate immune response aspect of the whole process, which then will progress to a T-cell activation or lymph node hypertrophy. And many of these processes are regulated by various types of various cytokines, particularly gamma interferon. They're also regulated by certain other processes such as CD28, CD40 ligand, which are essentially co-stimulatory molecules in T and B cell interactions. These processes then lead to an autoantibody response. In particular, we have anti-nuclear antibodies, ANA, and also a genetically regulated response to the nucleolus. And then this then finally leads to this pathological aspect of immune deposits in the kidney. And on the bottom here, you can see the timeline of these sort of processes following the exposures that we do. And it takes about a month to get to the end point of having pathology. But that only occurs in certain strains of mice. Other strains of mice won't really have the immune deposits, but they will have autoantibody production, like the Black 6, for example, or the AJ. And then right down at the beginning there, the DBA2 mouse, it's down there because it essentially does not respond at all, has very minimal level of response to exposure to mercury. This appears to be due to the fact that they don't have this initiating cell death and localized inflammation that leads to the subsequent processes. So what we know from all these different mouse studies is that clearly there is a genotypic relationship here, gene-environment interaction relationship, where some mice will respond relatively well. Some mice will have certain features, but they won't actually have the end-stage pathology. And some mice, like the DBA2, just simply won't respond. So with this sort of subclinical model, we've been pretty successful in showing that we can actually model the human exposure to mercury. We can demonstrate these genetic requirements that exist not only in this model, but also actually can be observed in models that study idiopathic systemic autoimmunity. So clearly, there's a relationship between the immune response to mercury versus the immune response that occurs in systemic autoimmune disease, where we're unaware of what exposures may or may not be relevant to that disease. And we can use these genetically modified strains, especially these single gene deletions, to actually identify certain pathogenic mechanisms. The problems that exist, or the issues that exist with this particular model, are a lack of genome-wide association studies, both in humans and in animal models, for example. And there have actually been few studies using outbred strains. Hopefully this will change as we move forward, looking at this particular process to see if we can identify more of the genetic components that are involved in this without having to go to the process of using mutated mice to study that in greater detail. Now, with crystalline silica, and this seems to be a topic of one of the main topics of this symposium, and for good reason, it really is one of the exposures where there's a very clear association between human autoimmune disease and exposure to crystalline silica, or to silica dust, I should say, in its various forms. The experimental studies that have been done to date, and there really have not been a large number, but there have been the use of a variety of different types of animal models. The important aspect for this particular exposure in terms of using animal models is that there is a huge literature, both for humans and for animal models, on silica-induced lung disease, such as silicosis, for example. So there's this huge background of information that we can use to make some decisions about what to study and sorts of exposures that we can use that may be relevant. These autoimmune studies that have been done, the few that have been done so far, have used basically inbred healthy mice, but mainly lupus-prone mice. There's been one study on transgenic mice, and we ourselves have actually used an outbred strain. The lupus-prone strain that's been used by Jim Pesker here in the US is basically a model using the NZBWF1, and that's a cross between two different strains of mice, New Zealand black and New Zealand white. It's probably considered one of, or if not the gold standard for studying systemic autoimmune disease in mice. But there's really a huge amount of work that needs to be done to identify the genetic and molecular and cellular requirements of the disease as it is induced in mice. And certainly in humans, there's very little information in that respect. So in humans, the disease is essentially an exposure disease of occupational exposure. It causes silicosis. There is some also relationship to lung cancer. But for this topic, it's really a predominant risk factor for diseases like especially rheumatoid arthritis, but also lupus, systemic sclerosis, and also chronic obstructive pulmonary disease, which does have an immune aspect to it. There's a very variable frequency of disease features among the exposed individuals, which suggests that there is probably a very significant genetic involvement interaction and gene environment interactions as well. You can get silicosis in about 1/2 to 3/4 of the individuals if they're followed adequately after their exposure, because it occurs essentially for decades. Those patients who have silicosis can have increased antibody levels in their blood. That's about 2/3 of the patients. The presence of antibodies, especially the anti-nuclear antibodies that are common in systemic autoimmune diseases, there's around about 1/3 of the patients, and it can be higher in some other studies. Other features like end-stage renal disease, especially due to silica exposure, are much less frequent, occurring about 5% of the exposed individuals. And much less frequent is the development of diagnostically defined autoimmune diseases. But the important point here is that these diseases actually occur at about 5 to 10-fold higher than you would expect for idiopathic patient populations of rheumatoid and lupus, for example. And as we've just heard, there's, unlike the idiopathic systemic autoimmunity diseases, the risk patterns don't necessarily show a sex bias. So we don't really see huge increases in disease in exposed women versus exposed men. It seems to be very similar, perhaps even a slight increase in men over women, but it's this certain sex bias that's observed with idiopathic disease is not observed in exposure to silica. So we've been interested in looking at this because not only because of the relevance to human autoimmune disease, but also because it can allow and can really allow us to study the real important aspects of developing disease following exposure that is actually a genetically relevant disease, but also an exposure relevant disease. And to do this, we've decided to use an outbred mouse model because it'll provide us, I think, with a much greater idea of what the genetic contribution may be to these sorts of exposures. And so we've decided to use a diversity outbred mouse model for this. This is a model that's been developed over the last decade or so. Essentially, it's based on taking 8 founder strains. 5 of these are the common laboratory strains and 3 are wild-derived strains. They're essentially mixed in a breeding pattern that is essentially random. And then the outcome has been 2 different types of mice. Continued outbreeding essentially has given us the diversity outbred mouse. And then taking some of those mice and actually generating inbred strains has given us the collaborative cross lines, which are around about 60 or 70 different inbred lines, recombinant inbred lines, based on those initial inbreeding crosses between the 8 different strains. The good thing about this is that it's roughly estimated to be about 45 or so million segregating polymorphisms within these strains. That's actually more diversity than we can observe, that's been observed in human populations. The largest issue with these particular studies is that they're, as we've heard with lupus, for example, or some of these other autoimmune diseases, there's a complex pattern of trait regulation at these sort of population levels. And that means you've got to use very high sample sizes, particularly if you're looking at a multigenic disease model where individual genes may be contributing only a small level of effect to the final outcome of the phenotype. So that means using hundreds and in some cases thousands of mice to actually do these studies. So just to give you an idea of how we run these sorts of studies, the exposures that we're doing, we've decided on using a single transoral exposure, a relatively high dose of 5 milligrams and 50 microliters of saline. This is a commonly used silica material, Immunosil 5. It's 5 microns or less. The medium size is about 1.6 microns. What we're aiming here is not to replicate human exposure profile. That's essentially impossible because it occurs over decades in humans. What we're trying instead to do is to elicit an autoimmune phenotype that's actually consistent with the relevant human exposure that's been identified in humans. It's been argued, although the evidence is not that strong, but it's certainly been argued that in humans, the exposure intensity rather than cumulative dose is important for autoimmunity. And in the studies that we do, we look at about 26 or so disease parameters, and these are mostly assessed after 12 weeks of exposure. What I'll describe is a current cohort that we have of about 400 animals that have been exposed to silica, and 70 have been exposed to saline. They're a combination of male and female mice. We look at the lung inflammation in these animals. We look at various features of autoimmunity, and we also look at some features of systemic disease. And so I'll just go relatively quickly through some of this. Basically, we look at a whole range of different lung parameters. We're looking at the lavage fluid for various cytokines, various inflammatory cytokines, the level of protein, and also the level of cells. In terms of lung histology, we'll look at inflammation in the lung and various aspects, alveoli and so forth. And that gives us what we call a total lung score. And you can see in these mice that there can be quite a wide range of responses in some of these exposures. So for example, IL-6 in the lavage fluid, there's a small population here that have very high levels. And many of the mice really have very low, to essentially almost normal levels of expression of IL-6 in the lung, for example. When we look at autoantibodies, the one thing that we find with these mice, and we've not looked at a large number of autoantibodies, but pretty much every autoantibody that we've looked at is elevated in these animals to some extent. They have obviously an increased level of serum antibodies to begin with these exposures. They develop anti-nuclear antibodies over a 12-week exposure period. That's essentially the highest levels occur at this 12-week period. And then there are various antibodies, anti-chromatin antibodies, anti-CCP3 antibodies, rheumatoid factor, and so forth, that are common among a variety of different autoimmune diseases, especially CCP3 and rheumatoid factor, especially in rheumatoid arthritis, for example. And then there's an antibody response to what's called ENA5. This is a mix of about five different nuclear antigens. But these mice make very good responses to two of the components here, anti-SM and anti-RNP. Both of these responses are very common among systemic autoimmune diseases. Anti-Smith antibody, for example, is most commonly found in lupus, anti-RNP in lupus, and also other diseases as well as lupus. When we start to look at the systemic disease, we've not looked widely at this yet, but we've looked at a couple of different things. We've looked, for example, at the draining lymph node, the trachobronchial lymph node in mice. There's a single lymph node that actually drains from the lungs, and we see that this is increased dramatically in size in these mice following exposure. There is an increase in the presence of granuloma in this particular lymph node. There's also an increase in spleen weight, suggesting that there's responses occurring in the spleen following these exposures. This is just here for sort of a control example, if you like, that the body weight doesn't change in these animals. So when we're reflecting these weights of spleens and lymph nodes and so forth, it's not because of changes in body weight. These mice also exhibit some nephritis, not all the animals, obviously, but there's certainly a cohort of animals that will develop nephritis. They don't develop severe nephritis, so we've had some difficulty in establishing that the majority of these mice actually have proteinuria. There are obviously a small cohort that have proteinuria, but it's not a profoundly severe renal disease in these mice. So the main reason to actually do these studies is to try and find genetic relationships between the various phenotypes that we look at and the exposure to silica. And this has meant doing what's called quantitative trait locus mapping. The good thing about the diversity active mouse is that there is a genotyping array that contains about 140 plus thousand SNPs on the arrays. We can analyze each mouse in this respect, and then we can use various software packages to look at QTL mapping. And this will allow us to look at, for example, the haplotype effects of DO founders, and also the SNP associations within these QTLs of the various founders. So over here on the right-hand side, you can see an example, not from us, from another study, where they've actually looked at a bunch of mice looking to try and identify different gene relationships. And they've identified a very strong relationship here with a gene in the particular phenotype they're studying. And what they're able to show when you look at these haplotype effects among the DO founders, you can actually show along this particular QTL region that some mice actually have different responses. So for example, the red line here is the PWK mouse, and it's essentially showing the PWK has less of a response than other strains, for example. And so the idea is that genes within this region from the PWK may in fact contribute to this phenotype. They may be less likely to have the phenotype being examined. You can then look at this particular region in greater detail by identifying the various SNPs that may be involved here to see what genes may actually be involved. So we've been doing this now with a bunch of these different phenotypes that I talked about, and I'm just going to give a few examples here so you can actually see how the progress is going in the study that we're doing. What we've looked at is, for example, the granuloma formation in this trachobronchial lymph node, and this does actually give us this very good separation between our saline controls and our silica exposed animals. When we do look for QTL mapping, we actually do find quantitative trait locus on chromosome 11. It's relatively significant. And if you then do these haplotype studies to look at the various strains, it seems like there may be one of the DO founder strains, or I should say the genetic contribution from one of the founder strains seems to be having an effect here where it appears to be less less likely to develop this particular phenotype. It seems to be the genetic contribution seems to be a suppressive rather than a supportive response. And so far we've looked at these two regions separately. Here you can see this, for example, is the left-hand region, and this right-hand map is the right-hand region. And we split this up into the various SNPs that may be involved. Unfortunately, you can't see the genes that are involved here. It's too small. I can tell you that this is a very typical pattern that we find when we do these QTL analyses. We find a wide variety of different SNPs that may or may not be involved here. And so the real issue now that we're going forward with these studies is trying to identify whether there are in fact any genes or multiple genes within these regions that are actually contributing to this phenotype. That this is probably the most difficult aspect of the work that we're doing, is to actually take these observations and identify individual genes. It's a common problem doing these sorts of analyses. Another QTL that we've identified.
Sorry, Michael. For sake of time, so can you wrap up in a few minutes?
I can wrap up right now. Okay.
No, but
it's really so basically what I can tell you is that the QTLs that we've identified, we can identify them, certainly, yes, no problem. Can we identify genes that expose those genes that actually are relevant to those exposures? Not yet. No, we can't do that. It's simply at this stage we need to look at many more mice to actually try and refine these QTLs to smaller distances, to try and identify relevant either relevant genes or relevant regions within the genes that may be controlling the aspects. So let me just go quickly here because the time considerations. So silica exposure, we can do this in inbred and outbred mice. It's not a problem to actually produce the systemic autoimmune disease in these animals. The diversity outbred mice seems to be very valuable to do this in terms of identifying genetic loci. The issues that we have that trying to identify individual genes, we're not at that stage yet. And more significantly, the disease that we're seeing more resembles lupus than the other diseases that are associated with silica exposure, like rheumatoid arthritis and systemic sclerosis. And we haven't yet begun to really look at gene knockouts or knock-in mice to try and identify some of these genetic requirements to see if we can sort of focus in on more important genes that might be involved. So just a brief discussion. Basically, linkage of the environmental exposure and autoimmune diseases in humans is really hampered by lack of well-defined studies, but we can overcome that by using experimental models to approach these studies. The studies are the most useful if you've got an exposure that aims to induce a disease phenotype as opposed to mimic a human profile of exposure. We've done this very successfully now with the subclinical phenotype following mercury exposure. That certainly, we think, provides a roadmap for studies that actually might want to look at other subclinical phenotypes. We're in the process of developing models for silica exposure. It seems like the diversity outbred mouse is probably offering us the best approach to those sorts of studies, especially in complex traits like systemic autoimmune diseases. And so just quickly, this is the group that's involved here. You'll see all their names on the various papers that we've published. And the work that we do is actually supported by the NIH and has been for now a number of years. And I'll stop sharing my screen and go back. Sorry for taking so long with that, but it's a long, hard topic to discuss in 20 minutes. I'll take any questions.
Okay, thank you. Yeah. And of course, first question, how easy is it to compare the human and the mice with the human QTLs? Is it easy to find resemblance, or is that also still something that has to be developed? Because finding it in mice is one thing, but then linking it to the human population is something else.
Yeah, so yeah, as you're probably aware, a lot of the studies, especially with diseases like lupus, for example, in humans, really they come down to identifying a SNP within some genes. GTLA4, for example, some of these other genes. I mean, clearly the most relevant one is really the MHC region, because it controls antibody responses. But so far it's really very difficult either whether you're doing a human study or a mouse study. It's very difficult to say, yeah, this one gene is important. And I think that really speaks to the fact that these are multigenic diseases. And they're very diverse diseases. Even within a cohort that's just lupus patients, the actual spectrum of disease features is very variable. And that, I think, speaks to the fact that there's multi-genes involved here, and the contribution may be small amounts of contribution from individual genes that when you add them all together, gives you a genetic phenotype or genotype that's actually going to give you the appropriate phenotype. So for us, it's been a little bit discouraging, but we are finding loci that we can, I think, actually study further. But it'll be a time-consuming process to finally get to the final answer.
So it's clear that we are not there yet, and the answers are still to be found. Yeah. Okay. Thank you. Yeah, that is science. Yes. So thank you for your contribution, and yeah. Seems to be that time is too short, so a bit running over time, but therefore I announce the next speaker, so Dr. Tue Bjerg Bennike. So he's into immune diseases at a young age in his research field, and so he's a professor at Aalborg University in Denmark, and he will try to explain his work to us on the breach of immune tolerance. So I will stop sharing, and then you can take over the screen.
Yes, thank you very much, Peter. And thank you for the kind introduction and the option to present here at the EXIMIOUS Symposium. So the title for my talk is Autoimmune Diseases and Breach of Immune Tolerance. And I will try and give a broad description and a general introduction into how breach of immune tolerance can happen, what is needed, and the consequences. And I will be using the inflammatory bowel diseases and rheumatoid arthritis as examples. And thereby I'll try to tie together the other presentations. And like Dr. Ellen de Lange, I would like to highlight that I'm aware that the audience is very mixed. So I have prepared a talk to a somewhat non-specialist audience. So if you are familiar with this, please take it as a brush up. And I will also try and keep my presentation timely, so we finish in time for dinner or lunch, depending on what continent you're on. So let's see if I can find the laser. Here we go. All right. So as we know, the immune system is essential for our overall health and survival. And a critical element of the immune system is tolerance to its own and healthy cells and tissues. So in 1984, it was proposed that immunological inertness to self, termed tolerance, is a characteristic acquired in development rather than an innate feature. This also means that it's something that potentially can go wrong. In 1953, the concept of immune tolerance was defined as an ability of the immune system to prevent itself from targeting self-molecules, cells, or tissues. And we now know that this breach of immune tolerance can lead to autoimmune and inflammatory diseases. And that is what this talk is focused on, how this can happen, what is needed, and some of the consequences. So an aberrant immune system activity is where the immune system mistargets, which results in diseases, which can be autoimmune and inflammatory. I'm not going to go into the details about what the difference is, but these diseases can affect any organs in our body. And normally the immune system will identify or tolerate our own cells and tissues, and it will even aid in the removal of sick and dead cells. However, in autoimmune and inflammatory diseases, this tolerance of the immune system is breached, and both the innate or the adaptive immune system can then target otherwise healthy cells and tissues. This will result in cell death, inflammation, and autoantibodies in many examples. And some examples of well-known autoimmune or inflammatory diseases includes Alzheimer's disease, We also have several cancers, and there's rheumatoid arthritis, which you've heard a bit about, and then the inflammatory bowel diseases. And while the autoimmune diseases in general are fairly poorly understood, we do know that the disease etiology is multifactorial. And for this immune system tolerance breach to take place, several elements are required. And I will start by explaining a bit about the genetic factors and what we know about this. So these genetic risk loci are commonly not sufficient alone to cause an autoimmune inflammatory disease. And as an example, we can have mutations within the central tolerance, also known as negative selection, which normally ensures that antibodies do not target the host. But if the system is compromised, we may be able to produce autoantibodies that target, instead of pathogens, then healthy cells and tissues. And this can in turn activate an immune response. And if we do genomics, this allows us for calculating risk profiles for many autoimmune diseases in personalized medicine. And it's important to know that these autoantibodies are actually not uncommon in healthy people, as we also have heard, but they are a hallmark of most autoimmune diseases. And as an example, I would like to consider the inflammatory bowel diseases, which a lot of my research is centered on. So just a brief introduction. Inflammatory bowel disease, or IBD, is an intestinal disease where the immune system mistakenly targets the intestine. And normally we have these very fine structures in the colon where we have intestinal crypts. So this is if we look closely at the tissue, and these crypts vastly increase the surface area of the colon and are responsible for many of the functions. But during prolonged disease activity, these crypts will be destroyed, both in large intestine, the structures in the small intestine, and this will lead to a loss of function. And there are two main forms of inflammatory bowel disease. So we have Crohn's disease and ulcerative colitis. They have a prevalence of about 0.4%, and they are both increasing. And resulting a consequence of the disease is increased overall mortality, a vastly reduced quality of life. And also, like we have heard, these diseases are quite expensive. As an example, IBD has an estimated cost to the European healthcare system alone in the range of 5 billion euros per year. And just to look at the disease phenotype, so if we have a healthy colon or inflammatory bowel syndrome, then ulcerative colitis, we have ulcerations within the mucosa. And in Crohn's disease, we have a thickening of the mucosa, and it can be penetrated by fissures. And I have included some pictures just to demonstrate what it looks like if we look with a camera during colonoscopy. But I do have to warn you that these images are not pleasant. So to the very left here, we see again a healthy colon with these nice preserved structures. And in ulcerative colitis, we see this clearly inflamed tissue, and we see this cobblestone appearance during Crohn's disease. So the phenotype is quite distinct for the disease in most cases. And if we look closer at ulcerative colitis, so these are some pictures from my own research, then here we look at the colon biopsies with a microscope. And I have stained the DNA in red, and in green we have one of the neutrophil associated proteins. And these circles we see here are some of the intestinal crypts where we're looking into the crypts. So what we see is that we see an increased infiltration of neutrophils when we compare to healthy tissue. And at a higher magnification, we can see that the neutrophils are actually infiltrating through the epithelial tissue. So we do see a neutrophil activity in this tissue, and we don't see this in healthy controls. And again, if we look at the genetic factor, we know that we have identified more than 230 genetic loci associated with IBD. So genetics really play a major role in IBD. But most of these loci are associated to several other autoimmune diseases. So if you have genetic loci for IBD, they are shared with rheumatoid arthritis, type 1 diabetes, and asthma, and many other diseases. So if you have IBD, you have an increased risk of getting one of the other autoimmune diseases as well. And of course, this makes sense when you think about where faults might lie in these genetic loci, for example, in the antibody production. And this becomes even more apparent when we look at the concordance of IBD in monozygotic twins. So the concordance is about 50% for monozygotic twins for CD, and it's a bit less for ulcerative colitis. And but it's still higher than in non-identical twins, where we only have the environmental factor as the identical condition. And in general, the concordance of autoimmune diseases is in the range of 5 to 67%. So this means that the genetic factor is associated to the autoimmune disease, but commonly it's not sufficient on its own to cause an autoimmune or inflammatory disease. And this brings us to the environmental exposures. So these are external elements that can induce immune system tolerance breach and cause an aberrant immune reaction. This can be done directly or indirectly in genetically susceptible people. So like we have heard, genetics loads the gun, but the environmental factors pulls the trigger and induce this immune reaction. So there are several known environmental exposure risks. We can name several chemicals, and mercury, as very nicely explained by Dr. Michael Pollard. But there's also pesticides, and especially smoking, as several of the other talkers also have mentioned, results in a higher risk of developing an autoimmune disease. And also dysregulation of the composition of the bacteria in our intestine, which is termed the gut microbiome, is another important environmental factor. And it's important to stress that the potential mechanisms by which these environmental agents contribute to disease remains largely unknown. But let's take a closer look at smoking. So smoking is one of the best known environmental exposure risk factors. It's associated to an increased risk of nearly all known autoimmune and inflammatory diseases. And some of the negative effects include an increased oxidative stress on the biochemical level and on production of free radicals, which in itself may induce mutations. We also have an induction of increased cell death and inflammation. And smoking may directly modify proteins, which in turn may trigger an immune system responses. And it's difficult not to mention rheumatoid arthritis when we talk about smoking and autoimmunity. And fortunately, I don't have to spend too much time explaining about rheumatoid arthritis, but just very briefly again, it's an autoimmune disorder which mainly affects the joints, and ultimately it will lead to a joint destruction. And it affects between 0.5 to 1% of adults. And again, our understanding of the etiology is incomplete. What we do know is that exposure to smoking is the environmental risk factor with the highest impact on risk. So smoking has a vast impact on rheumatoid arthritis. And I'm going to come back to this point and give some potential hypothesis as to why this may be. Because I also want to mention risk factors in inflammatory bowel disease. So if we here have say the age, the stage of life, early life at least, and on the y-axis we have if the exposure is protective or harmful in terms of risk for developing IBD, then we actually know that breastfeeding is protective in early life against developing IBD later in life. Then we have a number of exposures where we're not still certain about what the actual impact is. But we do know that immigration from a low to a high IBD incidence country and also antibiotic use is something that is a risk factor and increases the risk for developing IBD. And the same goes for smoking, even passive smoking. And especially enteric infections, that is infections occurring in the intestine, are also a strong risk factor for IBD. And of course, many of these things tie into the gut microbiota, especially antibiotics, smoking, and infections. And this is a very, I think, interesting and developing field because the microbiota we now know is part of developing the human immune system. And each and every one of you listening to me right now have approximately 2 kilos of bacteria in your gut. And these bacteria, they outnumber our cells by about 10 to 1. And they actually outnumber our genes by 100 to 1. So they constitute a massive expansion of the genetic material we contain. And in IBD patients, we know that there is a correlation between loss of species diversity of the microbiota and the disease activity index of Crohn's disease. I think interestingly, C-section, which we know leads to a different microbiota composition, does not seem to have an effect on IBD, even though this is still debated. But an explanation may be that studies have shown that the differences induced by C-section actually disappears by about 6 weeks of life. And the association between IBD and smoking may also be associated to that smoking may alter the species composition of the gut microbiota. So these were some of the environmental exposures in IBD and rheumatoid arthritis. So again, these may lead to biological changes that can induce an immune reaction in genetically susceptible people. So again, a single factor is commonly not enough, but we need the joint reaction to take place. So these aberrant responses to what we term self-antigens may be induced by exposure. They can, under certain conditions, trigger a chronic self-sustaining autoimmune inflammatory state. And it may be initiated by the innate or the adaptive immune system. And the autoimmune inflammatory diseases often involve the production of these autoantibodies, which then will target otherwise healthy cells or tissue, and thereby initiating a cascade reaction towards this target. And this may be specific towards a certain organ, as we have heard, or it may be a systemic, which is more in the case of rheumatoid arthritis. And this is what we term the immune system tolerance breach when this happens. And if we look at rheumatoid arthritis again, then 71% of the rheumatoid arthritis patients are positive for serum autoantibodies targeting a protein called vimentin, which has been modified by citronellation. Citronellation is a modification of the amino acid arginine. So it's a fairly small modification where nitrogen is replaced by oxygen, but it does result in a change of charge, which can have quite severe effects for the function of a protein. And again, this citronellated vimentin is the target of these autoantibodies, and it's found in lung tissues. And it has been demonstrated that it's increased upon exposure to smoking. So we now know that smoking actually induces citronellation. And citronellated vimentin has also been found in the joints, so in the synovial fluid of rheumatoid arthritis patients. Furthermore, changes to the gut microbiota has been reported in rheumatoid arthritis. This includes an overrepresentation of gram-positive bacteria and an underrepresentation of gram-negative bacteria. Now, of course, we don't know yet if this is causing or caused by the disease or the treatment, but even so, in one of my research projects, I investigated the colon tissue of rheumatoid arthritis patients using high-throughput proteomics technology. And I also found this citronellated vimentin in the colon tissue and the exact same sequences which we suspect these antibodies target. So the current hypothesis for rheumatoid arthritis is that the immune system here targets proteins which may have been modified, for example, by smoking. And this then leads to an initial immune reaction, a tolerance breach. And this may even happen elsewhere. This might happen in the lungs, in the joints, or even in the colon. And then the immune reaction takes place mainly in the joints afterwards. And if we move to inflammatory bowel disease, then up to 85% of UC patients and 79% of CD patients also have autoantibodies, and these have affinity towards neutrophil granules. So we call these P-ANCA, or antibodies targeting the cell wall of the yeast, which we call ESCA. And interestingly enough, about 50% of rheumatoid arthritis patients also have been reported to be positive for ANCA autoantibodies. So there are many synergies between these autoimmune diseases, and many of them share the same risk factors between most autoimmune and inflammatory diseases. So just to summarize, so I finish on time also. I hope I have demonstrated to you in this brief introduction to the triggering of autoimmune diseases that these diseases are really multifactorial. And an apparent immune reaction can be initiated under certain conditions, which may be induced by environmental exposure and trigger a chronic self-sustaining autoimmune inflammatory state with the innate and/or adaptive immune system in genetically susceptible people. And based on this, DNA sequencing of patients may allow for calculating the risk factors for the genetic component at least. And maybe in the future, we will be able to make certain recommendations to patients that for you, for example, it's very important that you don't smoke because then you are very much increased risk for developing these number of diseases. And this is important because we still lack appropriate methods to actually modulate these immune reactions, especially after they have taken place. And the current treatment is in most cases symptomatic and somewhat unspecific with severe side effects. So in my opinion, controlling the immune reaction therapeutically will be a central piece in finding a cure for most autoimmune and inflammatory diseases. So with that, I would like to thank you for your kind attention, and I'll be happy to answer any questions you may have.
Thank you very much, Tue. I've got one question here in the panel. It's maybe a difficult one, I guess. So someone is asking here, while smoking appears and exert a deleterious effect on Crohn's disease, there is also evidence that smoking protects against ulcerative colitis, so possibly via the nicotine-induced mechanism. Can you shed a light on that?
Yes, I mean, it's a highly debated area, and a paper was released a few years ago called "The Truth About Cigarette Smoking in IBD," because a lot of papers have been released discussing this, and it seems that you have a different effect for Crohn's disease and also ulcerative colitis. But as far as I remember, it has a protective effect against reoccurring flares, but the risk for actually developing the disease is still increased, and that's a different aspect. So if you contracted IBD, if you should stop smoking or not is one question, but if you don't want to get IBD, you should definitely not smoke.
Okay. I think that's a good message. Another question. Do I see it right that most often when potentially environmental exposures are involved in developing autoimmune disease, there must be a kind of cell lysing event where these proteins or DNA is released and that then breaks the self-tolerance, or is that not always the case?
So it's a very good question also. We know it's not always the case, but it is a central hypothesis also, for example, in rheumatoid arthritis. So we know that citronellation is centrally involved in this autoimmune disease. And commonly, the enzymes responsible for citronellation are only found intracellularly. So one of the hypotheses have been that if you have massive cell lysis, you can have release of these PAT enzymes, and they may begin to citronellate extracellular proteins, which the immune system is not commonly in contact with. But it is only one of the hypotheses, so it's a good question. But it may be involved in some autoimmune diseases, that is for sure. Okay,
thank you. I don't see any urgent question popping up anymore, so I think it's time also looking at our time clock or window to wrap up. And I think we had a very interesting session going from the clinic towards models and proof from the environment that exposures are quite important, and that's this breaking of tolerance in young age is not always young age, but an important point in development. So I thank my four speakers therefore, Ellen, Signe, Michael, and Tue, certainly the audience. I see we are now 42, I can see on my screen, but certainly have to say also to people supporting me directly, because I do the parole, but in fact, Katrin, Emily, Manosic support me all the time with the technical things, and certainly all the EXIMIOUS partners, and you can see them all a bit bigger than in the former slide, because I think we have a very nice project, but still a lot of work to go on. We, as everyone, had difficulties sampling and so on in COVID situation, but now we feel hopefully the last main peak of this year has passed, and we can really go ahead with our project. So thank you, thank the audience, thank to my speakers, and see you the next time on our third symposium, I hope. See you. Bye-bye.